Welcome back to the deep dive. Today, we are shifting gears completely.
Yeah.
Usually, we take a broad, sort of philosophical look at a topic, but today is for our listeners who are deep in the trenches.
That's right.
If you are a resident, specifically a plastic surgery or ENT resident, and you're staring down the barrel of your board exams, like the FRCS, this session is custom built for you.
We are doing a pure high-yield revision deep dive.
Okay.
Cutting all the fluff, no tangents, oh, this is sort of interesting. We are looking strictly at the embryology of the head and neck,
The big one.
specifically the foundations of craniofacial and branchial development. It's a dense, often terrifying topic, but it is absolute gold for the boards.
It really is. If you master this, you pass.
And if you ignore it, you will likely fail that basic science viva. It's that simple.
High stakes, high reward.
Yeah.
Okay, before we dive in, I have 3 quick favors to ask.
Quick ones.
First, if you're a regular listener, please just take 5 seconds, hit pause right now if you have to, and rate the show on whatever platform you're using.
It helps us massively, gets this content to the residents who really need it.
It does. Second, drop a comment. We build these deep dives based on your deficits,
Tell us what's keeping you up at night. Flat physiology, nerve repair, whatever it is.
and we'll cover it next. And the third point is arguably the most important for your exam prep. Today we're covering the basic science, the hard facts.
Right. The lists.
But the exam doesn't just ask for lists. It asks for clinical application. So if you want to see how this applies to a real patient, how to manage a branchial cyst, or the surgical nuances of a Tessier cleft,
You need to get our premium subscription.
that's where you'll find the Journal Club and the clinical cases deep dives.
Today is the theory. The premium feed is the practice. So go subscribe. But for now, let's get to work.
Our mission today is to strip down those terrifying lists, arches, clefts, pouches, prominences, and just turn them into high-yield facts you need to pass.
Let's do it.
We're starting with the beast itself, the branchial apparatus.
Yep.
So let's start at the very beginning. When we talk about the branchial apparatus, what are we actually looking at, and when does this all show up on the timeline?
Branchia is actually the Greek word for gills.
Right.
And that gives you a pretty accurate visual. These are paired, symmetrical swellings that appear along the lateral pharynx of a 4-week-old embryo. I mean, if you look at an electron micrograph, it really does look like the embryo has gills.
And how many of these arches are we dealing with?
Embryologically, there are 6 paired branchial arches, and this is a classic board fact, so circle this mentally.
A 5th one.
The 5th arch in humans is transient. It basically appears and then just disappears or regresses immediately. So for your exam, you are tracking arches 1, 2, 3, 4, and 6.
Okay, so arch 5 is a ghost. We've got 1, 2, 3, 4, and 6. Now, the thing that always helped me visualize this is that these aren't just random lumps of tissue.
No, not at all.
They're more like engineering modules. They come as a package deal.
Precisely. That is the absolute key to memorizing this without losing your mind. Every single arch acts as a container for 4 specific derivatives.
Okay.
Every arch has a cartilage element, which is the skeleton, a cranial nerve, the wiring, an aortic arch for plumbing, and myoblasts, the engine.
So if you know the nerve, you can usually guess the muscle.
Exactly. The anatomy just flows from there.
Okay, let's unpack them one by one, starting with the big one. The first branchial arch, also called the mandibular arch.
This is the heavyweight for facial development. Everything starts here. First, let's do the nerve.
Okay.
The first arch is supplied by the trigeminal nerve, cranial nerve V, specifically V2 and V3, the maxillary and mandibular branches.
And the cartilage. I feel like Meckel's cartilage is the buzzword everyone memorizes, but there's a nuance there that trips people up.
It is a huge trap. Meckel's cartilage forms, yes. But the trick is that most of it actually resorbs. It disappears.
Okay. People assume it becomes the mandible, but it doesn't?
It doesn't. The body and ramus of the mandible form from dermal mesenchyme that is adjacent to Meckel's cartilage. It's like a scaffold.
A template.
A template, exactly. The bone itself forms via membranous ossification right alongside it. However, the posterior part does persist.
And that becomes...
It ossifies to form 2 of the ear bones, the malleus and the incus.
Wait, let me just pause you there. I have a note here about the quadrate cartilage. Does that play a role in the incus too?
Good catch. You're getting into the weeds there, which is good. The quadrate cartilage is in the maxillary prominence of this first arch. It contributes to the incus as well, and it forms the greater wing of the sphenoid.
Okay.
But for basic recall, Meckel's gives you malleus and incus.
Got it. So Meckel's gives an ear bones, but the mandible forms alongside it. Now, muscles. If the nerve is trigeminal, we can logically deduce the muscle group.
Exactly. Trigeminal drives the muscles of mastication.
Masseter temporalis.
Pterygoids. But don't forget the outliers. This is where they catch you. The anterior belly of the digastric, the mylohyoid, the tensor villi palatini, and the tensor tympani.
Tensor seems to be the key word there for the first arch.
Correct. If it tenses, it's usually first arch.
Okay, moving on. Second branchial arch, the hyoid arch. What's the story here?
The second arch is all about the facial nerve, cranial nerve, the seventh. The cartilage here is Reichert's cartilage.
And what does Reichert's give us?
Think of the letter S. Reichert's gives us the stapes.
Completing the ossicles?
Right. The stapes, the styloid process, the lesser horn of the hyoid, and part of the hyoid body.
And the muscles.
Well, if first arch is mastication, second arch is expression, so the muscles of facial expression, plus the posterior belly of the digastric.
Ah, the split.
Notice the split there. Anterior belly was first arch trigeminal, posterior belly is second arch facial. That's why the digastric has dual innervation.
Classic anatomy viva question.
And finally, keeping with our S theme, the stapedius and the stylohyoid.
Okay, that covers the big two. Now let's do a rapid fire round for arches 3, 4, and 6. Third arch.
Third arch is the glossopharyngeal nerve, cranial nerve IX. Structurally, it finishes off the hyoid bone, the greater horn, and the rest of the body.
And muscle.
The stylopharyngeus muscle, the only muscle supplied by IX, and the internal carotid arteries.
Okay, fourth arch. This is where the vagus nerve enters the chat.
Correct. Fourth arch is vagus, cranial nerve X, but you need to be specific. It's the superior laryngeal nerve branch.
And derivatives.
Thyroid and cuneiform cartilages, the aortic arch itself, the right subclavian artery, and the pharyngeal constrictors.
And finally, the sixth arch. Also vagus.
Also vagus, but this time it is the recurrent laryngeal nerve.
Oh.
This arch gives us the intrinsic laryngeal muscles, the ones for voice production.
So arch 4 is superior laryngeal, arch 6 is recurrent laryngeal, both vagus. That is a crucial distinction.
Absolutely. If you remember that the recurrent laryngeal nerve hooks around the sixth arch derivatives, the anatomy of the thorax suddenly makes sense.
Okay, we've done the arches, the swellings. Now we have to talk about the spaces between them. This is where people get confused. Branchial clefts versus pharyngeal pouches.
It's all about orientation. Imagine you're standing outside the embryo looking in. The grooves on the external surface line with ectoderm are the branchial clefts.
Okay, external.
Now imagine you're inside the throat looking out. The grooves on the internal surface line with endoderm are the pharyngeal pouches.
External versus internal. Ectoderm versus endoderm. Let's start with the external ones, the clefts. What happens to them?
The rule of thumb for clefts is that essentially they all disappear, except one.
The first one.
The first cleft is the sole exception. It deepens to form the external auditory meatus, your ear canal.
And the others, 2, 3, and 4.
They get buried. The second arch grows downward and covers the third and fourth clefts, forming a temporary space called the cervical sinus.
Okay.
Normally, the sinus just obliterates. If it doesn't, that's when you get a branchial cyst.
Simple enough. First cleft is the ear canal. The rest vanish.
Yeah.
Now, the pouches, the internal grooves, these seem to stick around.
They do. They form vital structures. The first pouch forms the tubotympanic recess, so the middle ear cavity and the eustachian tube.
Which matches up perfectly with the first cleft forming the outer ear. The eardrum is the sandwich between them.
Exactly. The second pouch is simple. It forms the palatine tonsils.
Now, the third and fourth pouches. This is where the glands come in, and the migration gets tricky.
Yes, and there is a migration flip here that you have to memorize because it defies logic.
Okay.
The third pouch is physically higher up than the fourth. However, the third pouch gives rise to the thymus and the inferior parathyroid glands.
Wait, so the third pouch, the higher one, makes the inferior parathyroids.
Correct. Think of the thymus as a heavy anchor. It develops from the third pouch and migrates way down into the mediastinum. And because the inferior parathyroids come from that same pouch, they get dragged down with it.
Oh, I see. It drags them right past the fourth pouch derivatives.
Oh, exactly. So they end up at the bottom of the thyroid.
That's a great visual. So that leaves the fourth pouch.
The fourth pouch forms the superior parathyroids. They don't migrate nearly as far, so they stay up top.
That is definitely a board question trap. Third is inferior, fourth is superior, and the fifth pouch.
It's often considered the ultimobranchial body. It gives rise to the parafollicular C cells of the thyroid, the ones that secrete calcitonin.
Okay, let's zoom out from the neck and look at the face itself. Timeline is roughly the 4th to 8th week. How do we go from this weird embryo to a recognizable face?
It's a puzzle. 5 pieces or prominences surrounding the primitive mouth. You have the unpaired frontonasal process, paired maxillary processes, and paired mandibular processes.
And the front nasal process, that's not a branchial derivative, is it?
No, it is not. That's a key distinction. It's formed from mesoderm ventral to the forebrain. It develops these thickenings, the nasal placodes, which then form the medial and lateral nasal processes.
And the merging of these processes sculpts the central face.
Right. It's like a zipper closing. The 2 medial nasal processes merge in the midline. They form the philtrum, Cupid's bow, the nasal tip, the septum, and the primary palate.
And the lateral ones.
They form the nasal alae, the wings of the nose.
And this whole dance is driven by some heavy-hitting molecules.
Yes. You need to know the acronyms. FGFs, BMPs, sonic hedgehog, or SHH, and retinoic acid.
Sonic hedgehog is always the big one for midline.
Absolutely critical.
Which brings us to pathology. When the fusion goes wrong, we get clefts. This is our bread and butter. So can you walk us through the pathology based on which fusion fails?
Sure. Let's start with the most common, cleft lip. This happens when there's a failure of fusion between the medial nasal process and the maxillary process.
Okay, so side of the lip fails to meet the middle. What about a true midline cleft?
That's a Tessier cleft. That occurs when the 2 medial nasal processes fail to fuse in the midline. Very rare.
And often associated with other problems because of that sonic hedgehog link.
Exactly, for brain anomalies. Now, a Tessier 3 cleft is a failure of fusion between the lateral nasal process and the maxillary process, right through the alar groove.
And finally, what if the mouth is too wide? Macrostomia.
That's a Tessier 7. It's a failure of fusion between the maxillary and mandibular processes out laterally.
Excellent. Knowing the fusion partners is high yield. Now, let's move up to the skull. Cranial development. It's not just one type of bone formation, right?
No, it's a tale of 2 ossifications. You have the skull base and the cranial vault.
Different jobs, different development.
The skull base sphenoid, ethmoid, basio-occipital needs to be rigid. It supports the brain, so it develops from cartilage precursors. That's endochondral ossification.
And the cranial vault, the top of the skull.
That needs to be flexible. It has to get through the birth canal and then expand, so it's membranous ossification.
Straight from the dermis.
Right. No cartilage stage. This is your frontal, parietal, and squamous parts of the temporal and occipital bones.
And these bones are separated by sutures and fontanelles. Key timelines for closure.
You need to know 2 dates. The posterior fontanelle closes early, by 3 months. The anterior fontanelle stays open much longer, usually closing by 18 months.
And what drives the skull to expand? Is it the bone itself growing?
No. And this is fundamental. The suture is not a growth center, it's a growth site. The expansion is driven by brain growth.
The brain grows, pushes the plates apart.
And the tension stimulates new bone formation at the suture. So if the brain doesn't grow, you get microcephaly. The sutures fuse.
And with hydrocephalus, the pressure keeps them open.
Exactly. And the dura mater underneath is the signaling master controlling it all.
Okay, we can't finish without talking about the 4th germ layer. The neural crest. Why is this tissue so critical?
The neural crest is just fascinating. These cells are generated at the neural folds just before the tube fuses. They are technically ectoderm, but they behave like mesenchyme. We call them ectomesenchymal.
And they migrate everywhere.
Everywhere. They are the nomads of the embryo. They pour into the branchial arches. They form bone, teeth, muscle in the head and neck. But they also form the adrenal medulla, melanocytes, and the entire autonomic nervous system.
And because they migrate so much, they're vulnerable.
Extremely, highly susceptible to teratogens like alcohol and retinoic acid. If you disrupt their migration, you get a whole spectrum of issues.
Not just a facial deformity.
No. Cleft palate, cardiac defects, thymic aplasia. This is the basis of Treacher-Collins or DiGeorge syndrome.
So to recap, facial development is this complex interplay of migration and fusion, driven by cranial nerves, all reliant on this pluripotential neural crest population.
That is the summary. If you know the derivatives of the arches, the fate of the clefts versus pouches, especially that parathyroid flip, and the fusion points, you're in a very strong position.
And that brings us to the end of this revision deep dive. We kept it tight, factual.
But remember, facts are useless without application.
Which is why I'm going to remind you one last time. If you want to see how a Tessier 7 cleft presents, or how to surgically manage that branchial cyst, you need to listen to our clinical cases episodes.
They're available right now on the premium subscription.
It's worth the investment for the exam prep alone.
Seeing the pathology makes the embryology stick.
Please rate the show if you found this helpful. It really does help us out. And leave a comment telling us what topic you want to revise next. We'll see you in the next deep dive.
Good luck with the studying.
One final thought before you go. We talked about the neural crest being the fourth germ layer. Just consider this. The same cells that make the dentin in your teeth are the same lineage that makes the adrenaline in your adrenal glands and the pigment in your skin.
It's incredible.
Evolutionarily, it's just amazing that one cell population can be so versatile. It really makes you appreciate how interconnected everything is. See you next time.